don't happen for whatever reason, but when they do. So I'm going to welcome Nabil Jamshed, our new Director of Corporate Governance. You all know Nabil, but he's well and truly established now, and there's a degree of comfort in just Nabil sitting next to me. And what I mean by that is you've had impact already. As we'll come to during the meeting, there's so much going on at the moment. There are so many responses we need to make for national plans, etc. We've got to be absolutely on top of it, and we've got to get the basics right. And that's what Nabil will be helping us to do as we go forward. And yeah, just to remind you, we all know that the meeting is being recorded. Also, Simon Blake, he'll join us. He's got one of those days where there's about 4 commitments, bless him. So, but Simon will join us online, which is why we've got that. And I also want to thank Teresa Barker, our Chief Nursing Officer, who has left us, and she was working with us for over 3 years, and 2 years as a chief nurse. And thank her for all the work that she has done over those couple of years. And David too, thank you for being interim and supporting us in the short term. Thank you very much, David. I really want to acknowledge Anna's last board meeting. We'll come to thank, and we'll have plenty of time to thank Anna for all that you've done, but I want to acknowledge at the top of the meeting that this is your last board meeting. And we will come back to that later. We have people observing the meeting. Catriona Darling, Deputy Director of Mental Health and Learning Disabilities and Autism for NHS England. Thank you very much for coming to join us. Local resident, I hear, so it's really good to have you here. Apologies, declarations of interest. We have apologies from Anil. So he a very, very good reason indeed, and he'll join us next time. Declarations of interest, if there are any additional, let me know from what we've already got. I'm not expecting any. The meeting is certainly quiet, and can I ask for the minutes of the Board of Directors meeting held on the 7th of August as a correct record, please? Yes, of course. Good reminder. We're not expecting, we haven't had any questions from members of the public, so we're not expecting any. And that concludes those first few items. We move on to the Chair's report. Well, as I've already referenced, there's so much going on at the moment. I think at the top of the report, I want to say about the National Oversight Framework. So I think the way I'll play my report is I'll give you some of the strategic issues that are going on at the moment, give you my perspective as chair, what I've been up to, networking, building relationships with stakeholders, etc. And then we'll pass over to Jane to talk in a bit more detail about some of these issues. But take, for example, the National Oversight Framework, where we are with that, a little more detail about what we're doing about it. And then that will be a theme as we go through the meeting. And then I think probably as we did last time and the time before, we'll take two of us will take questions at the end so we can give plenty of time for it. So the National Oversight Framework, as you see there from the report, we have been placed into segment 4 from segment 2 and very low down on the comparative league table with mental health and community trusts. Now, we've known about this for a little bit of time, but it is something we're taking really seriously. And as I've heard some of you say, it's about how you respond to these things. It's immediately in the medium term, and how you make corrections. I do want to say that, as we've seen at our patient story, a lot of the stuff we do here is exemplary. It's high quality. It's brilliant. We are a very large organisation. We're very complex. Clearly, we're going to have problems, and the criteria this time around in the National Oversight Framework, we are found wanting. So we need to put that right. And as I say, more detail about that. We're going to be under scrutiny for that, and that's a good thing. I think actually me and Cheryl, you were at a meeting with NHS England just now on the people side of what we do. Jane and I will be going up to the regional office on Monday to talk through about the implications of what we're doing about it all. So as you can, as we will see, what we need to do is to work together, pull together as a board, and make sure we can address this. And we have responsibilities from our executive directors to hold executives to account, to question that we've got the right plans. I think the one thing I would want to say is what you need to do in this situation is manage your stakeholders and manage your partnerships, because what we don't want to do is to have our stakeholders losing confidence in what we do. That would be, that's not good all round, and it certainly wouldn't be good for our staff and our service users. And I think one or two examples, the response we've had from our governors, we've invested quite a lot of time and energy into it the last couple of years, has been really quite encouraging and quite positive in the, oh dear, you know, we're concerned about this. We will, of course, want to know what you're doing about it to put it right. But, you know, we would have every confidence that the Sussex Partnership Trust will do that and would want to back us. We have our system, we have our integrated care system, who will play a part in obviously questioning, but also giving us support. So we put that right. On the system update, well, there's significant changes in that we have Surrey and Sussex coming together as integrated care systems. We do now have a chair, Ian Smith, who I've met on a few occasions. It was important for me to meet him on a few occasions. One about how we work with our system partners in Sussex, and now Sussex and Surrey, and what that means. You know, for our acute trust for primary care, we've been working well in the Sussex system, but now we'll be doing that with Ian's chairing and also Surrey in mind, which takes them on to the point about we have an automatic allegiance with Surrey anyway, because of the Surrey, is it Surrey Heartland Borders? The Surrey Mental Health Trust. Surrey and Borders Mental Health Trust. We always work very, we're neighbours. We need to. And this gives an opportunity to work even closer together. It's you know, some clinical partnerships, working on things that they do very well, and we can, you know, share. Same with the other way around as well. So we've got quite good relationships with Surrey and Borders, and we'll keep that going. I've met the chair of Surrey Mental Health Trust on a few occasions with Ian Smith as well. So we get the line sorted out as to how we want to go forward. I think just a couple more things. Yeah, I wanted to say that Claire Murdoch, the National Director of NHS England, as we know, has stepped down. She came to see us before she stepped down. She had a day with us, which was really good, was very encouraging. Saw the new hospital being built and met Oliver and other key players. I just wanted to thank her for all that she has done over the enormous amount of time. She has really shifted the dial in mental health unquestionably, and she will be a big loss. I also wanted to thank Anne Eden, our regional director. She has notified us of her his retiring, and I wanted to thank Anne as well. She's given us huge support over the years, but was very supportive to me when I was newly appointed. We had a really good annual members meeting, well organised by the team, thank you. And again, the governors took a bit of a centre stage on that meeting, which was really really helpful. And we had a couple of excellent presentations about the work and clinical models and transformation that we're doing. We did have a visit from Daniel Kellis, who's the chief executive of NHS Providers. He also went to see what he's keen to see is the innovation creativity. He went to see the housing work that we're doing. He is also taking the lead in helping member organisations such as us around the National Oversight Framework and influencing government on our behalf where we need to, we want to use that. For example, the metrics and the criteria that is used, you know, do we have any suggestions for improvement? We had a discussion about that. The Positive Practice Awards are coming up, and I think because of the things that are going on at the moment, that's going to be even more important. And we've had some incredible entries. There's a lot of positive approach to the Positive Practice Award, which is fantastic. I'll pause there. How about we take Jane, and then we'll throw it open.
Thank you, Sean. So, as you know, this is the second time that I'm doing the new Skylab report, and I've chosen to focus on the organisational culture because the national framework, one of the areas that is our weaker side that we need to really improve on is around people and culture, and our scoring in the metrics that are relating to the staff survey, and recommending this as a place to work and about speaking up. So I thought it would be a good one to really focus on. I'm not going to go through the report in detail because I'll take it that you've all read it, but I thought I'd bring it to life a bit just by I do regular breakfast meetings for groups of staff, and I had one yesterday with a group of staff who were impacted by the Corporate Services Review. And even though that was a year ago, I was really struck by how what impact that has had on those team members, and that was still having on those team members. They've lost people that they've worked with for a long time, and they acknowledge that no matter how well it could have been done, redundancies are hard, change is hard, transition's hard. I was very honoured that they could be as frank as they were with me. And I suppose that's one of the things I've been struck by as I've gone around services recently. I met with a group of social workers, and one of our international social workers talked to me about coming to the country and experiencing racism from our patients and from our staff. And I felt touched that she was able to be open with me, but also concerned that this has happened in this organisation. So, you know, as I go on my visit, I see dedicated, innovative staff who are passionate about what they do, passionate about making a change to people's lives. But they're doing that within a context of immense change, uncertainty within the trust, but uncertainty nationally as well. I was really struck by, I had somebody come to my office the other day in floods of tears because their visa was about to expire. And she'd been brought over to work with us on a visa, and she was worried it wasn't going to be renewed because of what was happening in the media and because of the flags that were being put up across and what that would mean for her. Once again, I was honoured that she was able to speak to me about that, and it was literally, she was walking past my office and my door was open and she came in. But and that one has been sorted. Thank you for me. But I suppose it made me think about, you know, as the social worker that talked to me about her experience of racism, that was in work, but also outside of work. I've had people talk to me about domestic abuse, about worries about what their future holds. Is another CSR going to happen? We hear about all of the changes in the media that are happening to the NHS. How's that going to impact us? And not being able to give any certainty to people about what the future means, it's quite difficult. So I suppose I say that to say that this is within the context of the whole of the NHS, but we have very specific issues in Sussex as well. So it's both. But alongside that, people have their own lives as well that they're navigating, and their own challenges that they're navigating, and their own pressures, people who have illness, you know, and things that they're managing. And all this adds up to an impact on our workforce, which then impacts on our patients as well and patient care. And so it's really important that we get this right, that we actually attend to this and we don't pretend it's not happening and think, well, CSR happened last year, what, get over it. You know, it happened last year. We need to acknowledge that these things last and these things build up and people have been damaged by this process. And we need to think about how we work with people to heal, also acknowledge what's happened in the past and to move on to the future. So as we look to the future, I think one of the things we're really doing is encouraging people to fill in the staff survey, because the more we hear from people, the more we can actually attend to what they're saying. Whether that's a good story, a bad story, a challenge or a celebration, we want to hear from them. We want to hear from as many as people as possible so that we can listen, but we can also be present and hear what people are saying, and we can empower them to act and act ourselves. So I was thinking about Freedom to Speak Up, and I know we've got the Freedom to Speak Up Guardian coming, but one of the NOF metrics that we didn't do so well on was around people's ability to speak up, or feeling confident to speak up. And it's not just about listening and acting, it's also about empowering them to act as well. So it's about that shared ownership which then links to our continuous quality improvement journey, and really emphasising how important that is going to be in our cultural change. The listening, the empowering and the acting, and actually being open and transparent with people about the uncertainty and not pretending we know the answers, but because we are living in an uncertain environment at the moment, but also taking seriously what's happening to people in their personal lives, but also in their work lives, and believing the stories they tell us. So I suppose, I know it's not exactly what I wrote in my report, but it's sort of, as I've been going around services and meeting staff, it's sort of brought to life a bit about what I've written in the report. I also want to just acknowledge that Dan has had a significant hand in my chief exec's report. He has been really supportive in me trying to really put something that's transparent, but also backed up by evidence, and he's really helped with that.
Okay. Oh, we have time now, so over. Actually, I know that Lynn wants to come in, and also be quite good to bring from and show them, because you just had a meeting with NHS England, get an update on that about our staff survey, etc. But Lynn.
Well, I just wanted to say, when I sat and read the papers at home, this report really leapt out at me. And I didn't realise the two of you had done it together, so you were going to get all of the credit. Because actually, but it is I think it's your spirit, actually, Jane, that is in this report. And I read it, and it just gave me such great hope that we were focusing on absolutely the right thing, which is the culture of the organisation, so that people feel safe, they feel heard, all the things that you've just described, so I won't go over them again. But it was just being new to this organisation and seeing that report really lifted my spirits, and I just thought this is a great place, an honest place, and we've got a lot to do, but my goodness, aren't we going to get it done? And it was just spot on. And I loved the fact that it was also beautifully referenced. Jane, I just think from my perspective, we can take a lot of assurance from this approach in terms of it being the right way that we want to see things go.
And that's what it's all about, isn't it? It's getting the assurance.
Yeah.
Getting the assurance from the things that really matter, core.
Just on the theme of hope, one important aspect of the work we're doing that speaks to the paper I wanted to mention relates to creating an environment where people with lived experience are nurtured, valued and supported. And with Fumi's support, we're developing a lived experience workforce plan. And we've got, at the moment, 200 people with lived experience working within services, 65 peer support workers embedded in clinical teams, 16 peer workers working within our recovery college. I went to our lived experience workforce conference yesterday, which is part of the co-production of this new workforce plan. And the energy, the positivity and the hope in the room was palpable, and they're a really important part of our workforce to be cherished.
Yeah, just, looking at, Jane's report about board visibility, and us being accountable for what we do in terms of of our people culture. I just wanted to say that earlier in the year I had noticed something and brought it to the attention of obviously for me, who's head of people, and I was just really impressed with just how she dealt with it, just like really professionally, and just got onto it. And I think it's by when we do notice these things, taking it through to the right channels, and then trusting that our leaders do. And I was really impressed with how she handled that. So I just wanted to say that I am seeing that happening.
Might be a good time to ask for me, Rochelle, to come in. And just on that, to link it just to what Abio was saying there, that bought something, dealt with it very well. However, we're having staff in this organisation that don't feel able to speak up for whatever reason that is. It'd be quite good to get, to unpick a bit. It's good that we've got the Freedom to Speak Up Guardian coming in later to the annual update, but I think that's over to you for me, but welcome, Simon.
Thank you very much. And just to start by echoing where Jane had started from, that culture is, I wrote some points down here about it being the biggest driver for quality, safety, and retention, because when we get the quality right and our staff feel safe in an environment where quality is at the forefront of everything, then they want to stay in those organizations. Our staff survey is a symptom of the culture in which that people experience, and every team is a microcosm of the culture within those particular places. Now, what that means for us is this is a really good opportunity to be honest about the challenges, which the North gives us an opportunity to do, but also our strategy. And when we have this conversation as an executive team, we always start by saying, actually, let's remember our strategy, because that was co-produced with 3,000 people. So we have a plan. And let's also then remember that we have a vehicle to deliver that plan, which is our continuous quality improvement. But there is a need to bring people along on that journey. And the honest truth is that people in places, as Jane is giving by examples and what Abiola mentioned, don't always feel safe to speak up. They don't always feel valued for their contribution. And not everyone feels optimistic about the care and the future that they have in this organization. And we mustn't forget that, because those people are then the voices that we need to convert. Because when we don't convert them, other people can see what their experiences are. And there is something, I say, in behavioral science about when you leave another person's experience, through their experience, that becomes your experience of the organization as well. So that's why there's been a big focus around the staff survey, for recognizing that the staff survey is a dot on our journey towards cultural improvement for us as an organization. We did a deep dive report, I think 4 or 5 weeks ago, where we talked about it. And I thought it was a really important one to just share what we've done as an update, since in the past 8 weeks, some tangible steps that we've taken. We rolled out a 16-week engagement and communication plan with divisional toolkits, professional level toolkits. We've had 26 executive site visits between the end of August and now. We've had 5 roadshows with more planned. We have a daily staff tracker to sort of see how things are going, so we can pick up things. And my executives around the table are looking at what that looks like for their own functions as well. We've been saying something about embedding, he said, and we, you said we did thing, and we, I'm sure Cheryl will talk to this in a second, because we met with NHSE this morning. And it's pointed out, and we've heard that a few times, there's also something about recognizing you said and we didn't. So if there are spaces where people have said something and it's come to our attention and we haven't done it, part of this cultural change is being honest about that. And I think, we really welcome having such amazing clinical leaders in Oliver as our chief medical officer and David as an interim chief nurse in driving that culture change with that whole new journey, that recognition. So we are seeing progress on our staff survey. But I think one of the biggest things that's coming out is really about that leadership visibility. It's really about ownership of the optimism and the hope in where we want to get to, and enabling our leaders, both at the clinical level and our operational leaders, with that vehicle. And that vehicle is our CQR. Cheryl.
No, a couple of nice things.
Well, from a NED point
Yeah.
of view, I think.
So I personally, I think it was a good shout to me for inviting the interview, since it was noticed that our NEDs are not close. So I think that's good. They were very interested in the overall board, how close the board are, how close the non-executive directors are to this issue around staff engagement and staff and survey. And I was able to say that it's a shared target between executive colleagues, and that she has an opportunity, particularly with Oliver appointing new clinical leadership team and David bringing a new perspective on the nursing side. So that was very interesting. They did say they were going to take a closer look around the assurance that the board have been getting around this particular issue. And that got me thinking about how much time is spent at the Quality Committee looking at this. And obviously I don't have history of that. And also to what extent we kind of minute our board away days and importantly minute the challenge that comes from this, because there's a way of documenting that so it is actually seen from a record. So that was interesting. The other points that they made, which I thought was really interesting, and I can reflect on this as a fairly new NED as well, they say that whatever they get from SPFT is really high quality in terms of the presentations and the reports, but there is this disconnect between what is seen in terms of this presentation, and it wasn't just about staff survey here, this was a more generic point, what is seen versus what the data is telling us. And the question is how we translate what the quality of what is in this boardroom with what is going on further down the organisation, and how we use our values around compassion, accountability and optimism to really drive that. And I think there's a question around, I have assurance at this point that Burnley has got her executive colleagues really close to her, and you've talked about the road shows that you're doing, but actually what is the expectation of our senior leaders underneath the executive team and what their role is. And I think that question around, we like what we get from you, we like what we're hearing and what we're seeing, that needs to translate into the data. It's a really important point for us to be thinking about.
Really good report back. I know that Nitin and Anne want to come in. I'll just make a couple of quick responses. I think you're right about values driven. How we live, we're led by our values, but how does that translate? I have always, I know that we have a senior leadership team, and they're so crucial, all that we need to do going forward. So we need to know that about. I'm going to see them, I think next week. And for me, it's about valuing them, acknowledging how important they are. They are that transition, that conduit from what we do here to the staff at the sharp end. And if we're going to get any change on culture and the staff survey and all that sort of stuff that we will have targets for, we need to do, they're going to be absolutely key to us. And I know you've got training and development plans for that, and our plan is very comprehensive. I think the point about what's recorded and data and minutes, etc. And also, I know that we have talked at this board on a number of occasions since I've been here for 18 months is about, do we need to have a separate committee addressing all these issues regarding our staff and people? And we took the decision about 6 months ago to not do it at that stage, but to review it at the end of this business cycle. And I think we should. There's a good reason for it, particularly as one of the big parts of the metrics in the National Oversight Framework is around this. So we'll do that, but we can do it. We start having those discussions and making that decision now for the end of the business cycle, which will be at the end of the year. So I think we'll do that. Nitin and Anna.
Thanks, Chair. I think this discussion is really, really good. First of all, and thank you for the Chair's report and freedom to speak up. Clearly, we're doing a lot of activities since we're clearly, doing the things that we think we should be doing. I just had a couple of questions and maybe a couple of comments. This is probably something we're already doing. I mean, one of the advantages, we are in an ecosystem of other NHS trusts. A lot of these NHS trusts face the same challenges we do, same restrictions. They have gone through corporate restructuring, but clearly there's some who have come out really on top in this, right? They're 1 and 2 and 3. And we are at the bottom. And I would love for us, and probably you've already done this, but what are those people doing specifically, and can we learn something from the top 3, 4? Probably this already happened, I'm just throwing it out there. And the second bit is, when do we wait for another survey, a NOF survey, or do we do another internal pulse survey or something internally that we sense that all these activities that we're doing, are they going in the right direction? I just wanted to get a sense of what you feel about that.
Close my hand up. Or should I go?
Oh, no, you go.
First, okay, yes. No, so very good question, and yes is the answer. So the number one trust in the country, for example, Berkshire Healthcare, we've met with them, and we've met with their team, and we're talking to their chief exec, and one of the concepts.
I'm so sorry, we've got a bit of competition outside for the
Oh,
noise.
the
Do you want
sounds.
to raise it?
I'll lean forward.
Just yeah, you speak up.
No worries. So we have met. We've met with them even as a local people team, and Jane works very closely with the chief exec, and the common things are around engagement and CQI. So they have a 10-year journey on continuous quality improvement. They've already even shared their learnings and with us, with Jane has cascaded through to the rest of us. So we are, I think it's deepening our confidence that we're on the right path. The only difference is they did it, 10 years prior, before everything that's happening, and it's held them in good stead. We are slightly coming up on the back foot, but it's definitely all the right things, and hence why we have these assurance meetings with NHSC just to test and check the completeness of our work, and the gaps they've mentioned is what Cheryl mentioned earlier around. We want to see more of the board engagement and involvement with that. The second question around how will we know if it's working? Our first indicator for now is the levels of engagement, because if we've said that there's been a 5-year ongoing decline in engagement, in participation, and in results, the first test that anything we're doing is working is increased engagement. And the evidence of the engagement is just even seeing the completion rates, start to go up. We've worked for 8 weeks. The staff survey launched on Monday last week, and we are already above the national average in completion rates at the end of the which is something we shared with them as
You're
well.
6% up, aren't you?
Yeah,
This time
6%
last
up.
year.
Yeah. 6% up on our performance last year, we're 3% up on national, which has never happened before.
Yeah, Jane's going to elaborate, and I just wanted to say that I went to a trust in Northwest fairly recently who had significant improvement in their staff survey results, and this is a trust that's been under real scrutiny and in a lot of trouble for various quality issues over the years. And the two things that the chief people officer told me about was the thing you described as we said you didn't. But there was that, and they brought in a system in place where they every time something is raised, they log it and they show, and they're very transparent about it, what we did or what we couldn't do or when we're going to do it, and then leadership visibility, which we talked about, Jane.
So we are doing sense checks as we go along. It's going to be a quarterly rerun anyway, but the staff survey is an annual event, so that one won't change. This will have the staff survey this time, but it will only change annually. But the other metrics we are running constantly and just checking, and it's on the model hospital, so we can get a sense. We don't necessarily know where we are in the ranking as a result of that. We know we won't go above a 3 because we've got deficit support. It is something that Lisbon's team is actively looking at. And I just reiterate what Funmi said. One of the reasons we are going down the CQI route that we're going on at the moment is because Berkshire came first across all NHS trusts and staff survey repeatedly, and have had a 10-year improvement journey attached to it. And we're using that methodology that they used because of that.
So that, yeah, the continuous quality improvement we're investing in is vital. Anna, Dinesh, and Mikhail.
So I just want to make a slightly different point about culture, because culture is not one thing, and there are many microcultures within, organisations, and I think the job for us is to identify some of those microcultures where those kinds of disengagement, negativity, despair, hopelessness are kind of nurtured and fed. And I was very struck. I was at a meeting of senior clinicians not long ago, and one point that was made in that meeting was a sort of, it was also like a kind of question: how can we raise people up when we're carrying a 50% vacancy rate? Now, you might say, well, there's not many places that are carrying that kind of vacancy rate. But the narrative of, how can we do this when we're so under-resourced, I think, and if you look at the data, we've got particularly band 6 in the community and urgent care, and there are real issues there. We also know that Black heritage, workers are, there's an over representation on rates. So there are, I suppose what I'm saying is I think we need to understand those micro-cultures because of external factors and with them. And that's probably what you're doing already, but I just think we really have to listen to that hopelessness and not dismiss it, but try and understand it in very specific ways, very specific groups.
NHS England were very specific. So we talked about both sites and groups, and that they were saying they would expect to see how the need issues and how then we would try and label this is going on here, this is the reason. But of course, 100 sites, 100 subcultures, about 50 leaders, 2 sites a leader. Doesn't sound nearly simple.
Well, reciprocity, we're coming on to that later, but those frameworks help here enormously, don't they?
And I guess where it goes to is that we then have to give and have assurance that we have enough time to address those issues in aspects. But yet, when we are dealing with it at a lower level, it's then how we make that up.
Just to add to the point about that relentless focus on CQI and culture, one of the things we are very deliberately doing is talking about and using our values. I've interviewed as part of my doctoral research quite a few of the CEOs from those high-performing trusts, and one of the things they talk about is a relentless focus on talking about the values and using the values to shape behaviours. Because if your values just sit on a screensaver, they're cosmetic wallpaper. So that's something we are doing and very consciously need to continue doing.
Great. Dinesh and Kathy, and then we'll close up.
Something that Lynn said earlier, in July, I did 4 site visits, and 3 of the teams were exemplary. Their commitment, energy, enthusiasm was absolutely stunning. The 4th one was kind of bit dodgy, iffy, and I think partly what became very clear that was due to some more changes centrally being imposed on them. And they just kind of feeling very bewildered and didn't know what to do. And that's the question of local leadership and how we support them to make sure that they understand why something is being done. B, how they can be supported with minimum amount of damage. And again, I think I also attended one of the MAC meetings last month, and again, the commitment is really impressive. But quite often people feel that orders come from above. They don't know why. They just think that somebody doesn't really understand what's going on. So somehow we need to make sure that the communication is very clear and it says, these are the reasons why we want you to do this. If it's not possible, we need to know how can we support you.
And supporting the leaders and developing the leaders, which I know we've got in hand, is so important because there are good ways and not so good ways of doing all that transition and that change management that we're going to be doing. We're doing lots of it now, and there's no let up of that over the next couple of years. We will be transforming services, transitioning services. Thank you, David, very much. Kathy, and then we'll close with Lynn.
Yeah, I just wanted to pick up on that sort of the extent to which things are trickling down the organisation, that sense of empowerment, and that sense of the strategy becoming embedded and people sort of living and breathing it every day in their work. And I know, Sean, when we went to the unit in Hastings and we met the team that were talking about the fact that they, off their own bat, had implemented open dialogue, they could demonstrate the impact that that was having, but they've very much done that without any support and struggled a bit to achieve that. And actually, it was a brilliant modelling. And I sort of think, well, why haven't we got, as part of our strategy, that's one of our ways in which we're going to deliver our strategy. And we're doing that everywhere. And those people are championing that and leading that change. And I suppose it goes back to not just the optimism that we want people to feel, but also that sense of accountability and ownership of the change. And it reminds me of that story, two people in the field digging a trench. You say to one person, what are you doing? Digging a trench. The other person says, I'm digging the foundations to a cathedral. To what extent do our staff understand that what they do every day is contributing to our big transformational change strategy? So I guess CQI will help us with that. And I'm really sorry that I was on holiday when we had the workshop. Colin's going to fill me in over lunch. But, it's really making that join right down to
I think we all come to you, Lynn, but on this specific.
Yeah, just on the open, it's a really lovely example of an initiative and also an experience that staff have. So the Open Dialogue Initiative is absolutely something we want to support. It is one of effectively two of our high intensity user schemes that we're looking at as a workshop tomorrow, trying to pull this together actually a little bit more. And that team have been actually given additional funding recently from that, which came through NHS England our prices pathway. So it's definitely on our radar, but I think what you're describing is how our staff sometimes feel they are battling against a broader system. And open dialogue is actually a very profound cultural clinical change. And so there's if you like a cultural drag that they're having to fight against in order to embed that amongst within their service. So it's just a really interesting example. The other interesting example of that is how they just felt empowered. I know that they were saying that we've got enough support, we want to extend it, but they were empowered. However it was, they were empowered to do it, and it was innovative, and it was evidence based, and it was a good thing to do, and they've just got some funding for it. So, and it's again, that's the leadership. It's having that balance between communicating, constantly communicating, being clear as to why you're doing it, but also a bit of empowerment, not total central control. It's not the way things work. Please, Lynn.
So I'm going to come in, and David just put his hand up, but we've had a conversation about what kind of leadership do we want to be, and what kind of leadership are we? So if you think about the descriptions of people feeling done to, actually, if you were more of a servant leader team, you would be solving the problems that they're coming to you with, that are affecting them, that they want solutions for, rather than us saying, this is what we'd like you to do and we'll help you to do it. There's got to be a partnership around that. And we talked about it just very quickly, didn't we? And I still feel that the idea and the concept of the servant leader is something that would help right through the organisation, that we're here to fix things for people so they can thrive and flourish and feel like they're part of this whole organisation together. And I think we need to spend some time as we go through the quality improvement stuff, thinking about us as leaders.
And it will be during that quality budget.
Yes, it will.
Thank you, Lava.
Great. I really focused on servant leadership. Again, I have had a earlier conversation about this. I think what you get from servant leaders is just transformational. I think the other thing, it comes back to a point from the patients, is where we have compassion on our values, what does that mean in your leadership behaviours? And I know you're seeing that in your next level down and the next level down. And having those conversations when you're not seeing that compassion, because we've probably all come across people that say they're compassionate, but actually the behaviour is not always matched that behaviour. You know, I've had to take difficult decisions, but if you do it in a compassionate way, it transforms the conversation and people feel supported. And that's really critical, is modelling that behaviour.
And that's a skill, and it should be taught. Yeah. Great, thank you so much. I'm going to move us on to our board assurance framework, Nabil. And then we take a break.
Thank you. I'm Nabil Jamshed, Director of Corporate Governance. Thank you. I'll introduce the paper in terms of considering that being read. I'll draw out 2 or 3 key points for our discussion purposes to where we are and where we're heading. So I think the first and foremost thing to say is, I know the board probably was expecting to see a full document, and I'll come to that why we haven't got a full document in front of us in a minute as we go through it. But I think just to remind folk and just recognising the journey the Trust Board has been on in this process is really, really crucial. So the board had a workshop in November and March, facilitated by external who are our internal auditors as well, RSM, and they talked about how do we actually take our approaches forward to setting out risk appetite, risk frameworks, and the board assurance framework that we would like to see going forward. That workshop then led into executive workshop in September 2025, and from that workshop, what the output was to have a confirmation of our strategic risks, how they're defined, how they're written, alongside the risk appetite scores that were then confirmed back to the board members in a written form, and that was all agreed and approved as a collective, as that's what's been recorded. So I think it's really important to recognise it's probably the start of the journey, not the end of the journey, and we are going to be on a continuous journey. And I think on that, it's really important to acknowledge the board assurance framework is, to me, it is the best return to investor scheme that the trust can have. It is the only thing that we can hold on to delivering the strategy, what we just heard about cultural change, transformation, CQI. If our board assurance framework doesn't lift the spirits of this organisation, the hope that we're giving people, we're going to fail. And that's why it's really important that we do this properly, we do this thoroughly. So in that process, in the last few months, the board assurance framework has been through several committees, as it should, and there have been some really healthy discussions, really constructive discussions, and some really good feedback heard from folk, from my non-exec colleagues about how we can take this forward and make it more impactful. And I think that is the key reason why you haven't got the full document in front of you, because there's more work needed. And I'm committed to doing that work with the board as we go through that journey and bring that back in November in a workshop session with the board, do it properly and fully, and then we move on to bring it back to December meeting with the full document. So those are the key highlights. But in terms of where we are, just to remind again, we've had 10 strategic risks agreed, which are all aligned to the trust strategy. They all have got very detailed work, thanks to my executive colleagues and their teams, to do the specific work around what sits under that, i.e. the details around what controls we have in place, how effective they may or may not be, what actions are we going to do. And I think that action part is really important, and I'm really keen to deliver a change that is a felt change, not only the change that we see we're going to do. And I think that can only come from once we are able to validate actions moving the dials on that we see. I think that'd be the only litmus test we can put this through to. And henceforth, back to my point, this is the only return to invest scheme that I would want to see spend it, the details it needs, the attention is required. It's really important to focus on this. And I think some of this relates to, as we were talking about earlier, about our NOF scheme, where we are, the scoring that we've got onto, the scrutiny we are under. I think that is one element to it, but organizations who do this well are able to deliver the strategy. If that's what we're here for, this is a tool that will enable us to unlock those opportunities, identifying those risks, and do something about it. But I just wanted to pause there, Chair. So I think what I'm saying is we'll bring it back with a fuller workshop in November and a detailed paper in December.
Yeah, I think it's really reassuring, Nabil, you're getting a grip on this. We need to get a complete and utter grip on it. And I do like the point you're making that if we do, then we'll much more likely to achieve on our strategy and all the other plans that we've signed up to. And it's really important for us. So to be reviewed in November and in a workshop. Can I just check it? Very minor, but it's important. Do we have the, we'll schedule that in for the November workshop, and we'll approve it in December. No. But we've talked about the BAF on several occasions, and I think it's true to say that we've just not had the level of confidence in the BAF, in the final drafts of the BAF, but we will have, and you will help us do that. Thanks very much. Good. What we'll do then is
encapsulate somewhere within here, but we also separately do run a monthly exec report that covers off all of those North metrics. We'll also bring it to private boards so that everyone's clear, we've got a heads up on what's happening. But this is one of those key national oversight framework metrics, and we have seen an improvement on that from 53 down to 50 in terms of the length of stay. I think within that, there is sort of one of the sub metrics. It's not a specific national oversight metric, but one of the ones that we focus on is around older adult length of stay. And there has been an increase in that, and I'm sure John can talk about that in a bit more detail. But I think it's fair to say that is also the area where we're still seeing higher levels of CRFD than we do in adults. So there is always a link between I think the clinically ready for discharge and our length of stay position. Having said that, there is a very significant pieces of work that are currently underway in terms of the urgent and emergency care pathway improvements, which also encompasses our length of stay program and the 12-hour waits. So we've got weekly huddles. We've now gone through finalising, and it is on the agenda in the private sector later, the detail of what that scope of work will look like. It's already begun in effect, but we're also working through how do we put additional capacity into that program to make sure that we get those results as fast as possible, conscious that we're also, as we're coming into winter, need to make sure that we are in the best possible position in terms of flow. One, I guess that we should celebrate some things as well. In terms of our operational and national planning metrics, I think it is important to highlight that the reliable recovery rate for talking therapies has improved and continues to. And I think that is on the back of has been challenging in terms of some of the work we've been doing with the teams around balancing off the need to deliver the operational performance we want, but equally living within the budgets and constrained financial environments. And I think the teams have really risen to that challenge in terms of how they've addressed it. And I guess linked to that as well, partly linked to that is sort of the broader point around how do we make best use of our resources, our contacts per clinical, which is a metric we've sort of been monitoring and sort of started reporting now, has been improving. And I think they're at their highest levels we've seen for quite a long time, both of those. On the clinical contacts, what I will always caveat it with is it encompasses a range of things. And it's still something that's early for us as an organisation as we start monitoring that. The implementation of our new EPR system later on in the year hopefully will give us better data to really start sort of delving into it. But I think as a headline metric and as a indicator, and it is nothing more than an indicator, we don't use it as a sort of performance management tool, but it does allow us to see, are we actually starting to make improvements in that really critical area. In terms of the corporate projects, I think it's just worth highlighting formally that the Coombe Valley Hospital, I know we've had lots of discussions about it, but just to say formally, we were notified by Kia in August, and then subsequently had a meeting with them and NHS England in the beginning of September. And that project we knew would be delayed, but they've now said they had come back and officially said that they were delaying it till August 2026. So that would be a year past the original due date. They have submitted a revised set of plans, which the initial ones we did actually reject because we said there were still questions to be asked. I will say we've been working openly and transparently with them, and I think they've recognised the challenges they faced. So we continue to work with them to make sure that the plan that we now put in place will actually be delivered, and that the level of grip and control they as a company put into that program, and make sure that whatever date we do agree will be the date it arrives. It clearly does have impacts on us in terms of our original planning, and we've been working closely with all our local teams and staff and giving them as much information as possible, but being honest as well and saying it's still a moving feast in terms of exactly what those dates will look like. And I guess the other thing I just wanted to highlight was, you would all be aware that our new, I keep talking about this, a new EPR system is due to go live on November the 10th. And a lot of work has gone into that. But we are flagging that program as at risk at the moment. I think it probably is not unexpected. We always knew it will be a significant challenge to implement a new system. It is, by and large, everywhere in the country it has gone in. And there's been specific work done over the last couple of weeks about making sure we increase the training uptake rates. And I think colleagues, Oliver, David, and the teams have been really helpful, John, in terms of making sure we create the time for staff to be able to do the training, to make sure they feel comfortable and safe using the new system, because it is very different from what we currently use now, which is, I think we've all recognised, quite an outdated PAS system at the moment. So those are the updates I was going to give, Chair, and then I'm happy to take questions or direct to other colleagues as appropriate.
Good.
Just had two questions. I think one of the things you already picked up was percentage of patients waiting greater than 12 hours. That metric is very off, and the target is 5%. My question was, do we have the wrong target for the year, given that we are so far off, or is that more of an ambition, just where we want to be, rather than actually something we can achieve? And where do we think this target will be at the end of the year if we continue this way?
I'm going to say that you have absolutely spotted that we have got the target box the wrong way around. I apologise for that. I've clearly looked at this too many times. So our target was 95%. We are currently at 5%. And the work that we have done in terms of the UEC pathway, which we'll discuss in the next section, I think we'll go into more detail around what do we think the trajectory for improvement is going to be.
I have one other question, and this was around agency percentage. Our target is 2%. We are at 5.3. What does that 3.3% delta mean to our finance? Did we budget 2%, or did we budget a little bit higher and put a target of 2%?
So the target, you're going to have to all forgive me. I'm not feeling great, and I've already said something wrong. In the table there that you've got there, going back to the 12 hours one, the target is 5%. So i.e. we don't want more than 5% of the people waiting. Currently, we've said 96% are waiting more than 12 hours. Apologies. I've got to take less pills. In terms of the agency figures, those were the nationally set, in effect, cap figures that we were working through. I think internally within our local plans, we had set the aspiration to achieve those, but our financial budgets expected there would be a level of variance from that.
So we have it a little bit higher. So they're not going to feel the full impact of the 3.3% delta.
I think the important bit to recognise there is, while on the agency percentage figure, while there is a delta, on the overall pay figure, we are on the spectrum. Right. So I think we had recognised at the start of the year 3 planning for our organisation, getting to the national percentage was going to be quite challenging, given where we historically have been. We have made really significant improvements. Colleagues will remember at one point that figure was over, I think, 10 or 12%. So it's really significant reduction. But yeah, we're still not quite at the national cap figure for the agency spend.
Perfect. John, do you want to come in on?
It was just on your point, Nitin, around the target. So I think your question was, given where we're at, is only 5% of patients waiting for more than 12 hours the right target? So we talked about this a lot at the beginning of the year. My answer would be yes. Yeah, is it stretching? Very much so. But I think it's important because it talks to the quality and safety aspect of that. What we really wanted to do is get all our colleagues, operational and clinical colleagues, to focus on it. So whilst it looks difficult, it is difficult because patient experience and the quality and safety risks around it. I think if we said, well, we just want 75% of people to be admitted within that time, it would feel disingenuous. So yeah, it's the right target, but it shows the gap.
Just a few things, but the first thing I just wanted to say was just giving a bit of kind of perspective. This is my last meeting I feel to do that. I was just looking back at some of the stats from 3, 4, 5 years ago, and I mean I just wanted to particularly pull out the staff turnover, which in August 2022 was at 16.2%. So that we kind of need to keep that perspective on some of these metrics. And I think it's quite hard when we've got so much data, trying to absorb what's in front of us, just to have occasional kind of look back at where we've come and how far we've come over the years. That's my first point. Second point, and I've just got 3 points, if that's all right, was on page 11. So we've got the report on suicide. Oliver, correct me if I thought we were moving away from using the word risk assessments to using safety assessments. And I just wondered where we were with that, because I think the narrative now is that actually safety, I think that's assessing safety, is a better framing than continuing to use risk. I thought on page 24, where we've got the stats on restrictive intervention and percentage of patients. I mean, this is something that we do in quality, but perhaps just to think about for the future. We know that this is about a small number of high acuity patients. And I think somewhere in this, we need to reflect that and continually remind ourselves and others that it's a small number of patients that we're talking about with very high acuity, very complex things. And I'm not sure that comes across quite well. And the third point I want to make on productivity, and don't be surprised, I'm going to, because I worry about a kind of a one size fits all here that could be misunderstood over the longer term. And we create comparisons between clinical teams that do not reflect the complexity of what those teams do and why they have lower numbers, etc. So I suppose I'm just putting out a kind of so what question there. I get that we're doing this because the new narrative is productivity, but I would like us to be doing more nuanced work around why we have to be really, really careful that we're not comparing apples and pears and disadvantaging some.
Well, why don't Usman and John take the productivity question?
Just on the product, so I absolutely recognise that point. We've talked about it before, and I think we're really clear that we're using this as an indication of where we are. For me, there are so many variables. I'm more interested, I guess, in what the longitudinal trend looks like. And so within a particular area, while there may be differences, over a period of time, once we're able to sort of have that sense of what does it look like over a period of time, even within a particular division, for example, not necessarily comparing it to another division, allows us to ask questions of what has happened here, what has changed. I think this reporting is currently being sort of developed into and iterated, I guess, into slightly more nuanced. What do we need to exclude in order to get a appropriate comparative number? And we're doing it at quite a granular level within the divisions. and we're sharing it with them, because this is not about us trying to performance manage anyone. It is about saying, this is interesting. We can't kind of understand why at face value two similar sized teams look like they have very different numbers, and we're leaving it with them to be curious about, I guess, at this point. And I don't think, it absolutely is part of how we're going to have to address our challenges as we move forward. But I think especially right now, and probably for quite a period of time, this is much more about us saying, here's some information, it's posed some interesting questions, we'd really like you to have a look at it to understand it. And so what we present here is a very high level position. What sits behind it is a very granular level. It goes down to team, and we share that with those teams to be able to understand, because there are differences even within the different divisions in terms of the activities they do, they record, how, etc. it gets included.
Similar, really. So I chair the waiting times and productivity group, and this is an aggregate position. So to your and Usman's points, if you take the Brighton and Hove division, so that includes our talking therapy service. It also includes the Sussex Mental Health Line, the Rapid Response Service, which you can't compare to CAMS and community forensics. So sitting behind this, we have all of that broken down, and the reports that we share with the divisions are exactly broken. We'll try and use it in a way that is, I guess it's internal benchmarking. So we've used it helpfully around length of stay. We can use it around talking therapies. We can use it around waiting times in memory assessment services, where we have services that look very similar, delivered in different areas. And we ask ourselves the questions, why is that different? We're not using it, as Usman said, as a performance management tool and to compare apples and pears. So that caution is understood, but this is a high level figure.
We will continue this. But thank you for that. Oliver, just if you don't mind, adding suicide.
Can I also just respond to the productivity question as well? So there's a clinical case for recording our activity as well. As a clinician, I've learned it's more important to actually document and record small moments of activity as opposed to having very longer entries in the record system. So there's a real clinical argument as well to ensure we value the recording of activity, because actually it's a part of our record system. So on the suicide, we have rightly been asked, and as per NICE guidance, to stop actuarial risk assessments. The guidance is to continue to make risk assessments and then also have safety plans. However, I have a natural sort of inclination towards driving. I would prefer to actually make the right assessment, because actually that still implies some sort of predictive quality. That's not current guidance. So, but in the future, I would want us to be describing a risk history safety plan. But the point you're raising is, have we removed actuarial risk assessments?
I'm curious.
Sorry, yes, I wasn't. Can you repeat the question?
So it's really just, I think that on page 24, when we're reporting on restrictive interventions, don't bring out the fact that that's actually about a very small number, and that's been the pattern for. And I think that's quite important. It's important for the staff, it's important for patients, it's important for us to understand. Just to, I don't have a sort of solution in terms of.
Yeah, to bear it in mind. Yeah.
Something in a footnote or something that just acknowledges that.
No, that's really helpful. I think what we also need to do is aspect data, so we can see, so when we have fluctuations in patient activity, but yes, and I think on our graphs, how easy it is to follow.
Yeah.
Quick, on slide the targets for the neighbourhood mental health teams, we've got a target by November of 100%, and we only seem to be at 25% in July, but we've marked it green. So just an assurance that we're going to jump from. Slide 21. It was really about the It was really about the workforce issue, and it feeds in probably up in the finance discussion that the workforce optimisation SIP is under delivering, but it's mitigated by vacancy control. And I think there's quite a big question discussion for us to have about using vacancy control as a means to hold the financial, and also perhaps to understand better what the workforce optimisation programme is and whether it will be able to recover at the moment.
Impacting the agencies.
Yeah, well, exactly. All this hangs together, really. So it's just understanding how to join those bits together a bit, really.
I mean, we'll come on to it in the private section.
Thank you. I need to go on. We want to have sometimes quality.
Sure, very quickly, just to say Simon can't hear us very well. Can you
Okay.
please try and speak up?
Oh, okay. So speak up. So yeah, okay, that's fine. Thank you so much.
Chair.
Oh.
Can I just very quickly just answer
Yeah.
just because I can answer that neighbourhood one very fast.
Yeah.
So the November target is the EPR rollout target.
Okay.
So we've got everything lined up in terms of all the teams, all the restructuring's been going on in the community and everything else like this. But at the moment, the EPR rollout is structured into the new neighbourhoods, which basically is the accelerator at that point, which is why it looks a little bit odd.
Yes, actually, I knew that. Thank you for reminding me.
Would you like me to cover vacancy control? I'll try and keep it brief. So I can do this jointly with Fumi. So our vacancy control is being designed by our local oversight group. So all the vacancies in the trust have been classified into two types, either restricted or unrestricted. So roles within our inpatient services, our acute services, our urgent care services, and the majority of our community services are unrestricted. So they will go out for recruitment via the usual processes of divisional and HR and finance oversight. But we have classified a number of roles as restricted. So what that means is each month through the executive committee, we agree a cap of how many roles that we will recruit as an organisation each month based on levers data, recruitment, etc., etc. We've done that for 3 months. Each month we have now exceeded the cap. So the cap has been exceeded by an excess of unrestricted roles. And then we meet each month in a meeting which I chair, and all of the divisions and corporate services present the restricted roles that they want to prioritise. Last month, for example, we agreed 23 restricted roles over and above the exceeded cap. The recommendations for that then come to our executive committee, and we look at the rationale as to why we are agreeing those. Each of those roles has a quality impact assessment attached to it, and we look at the time or the length of time that any roles that have been held have been held, so we can be cited on the quality impact of that, as well as the productivity and the capacity element. We also look at where the recruitment has taken place, because we're really conscious that we don't want to disadvantage any service from a clinical perspective. And last month was a good example. We could see a very even split of roles being recruited to community, acute and urgent care services, and we can see that across divisions. Our caution is we don't want to see a community service disadvantaged over an inpatient service disadvantaged over CAMS, etc. We've also got in place a break glass process. So if people need to complete a recruitment activity between the month's panels, then they can bring that through a sit rep through to the exec committee. I'm quite confident, I'm very confident in the process that we have and the level of scrutiny that we have. It has generated a lot of interest and communication. But so far, I don't think it has disadvantaged any teams. However, there is a financial implication in terms of a recurrent and a non-recurrent impact, which we will pick up, no doubt, when we touch on the finance papers. But happy to talk to you more outside about it, Kathy, if that helps.
That was a really comprehensive answer. And it's ideal, in terms of getting assurance, for us to be assured. Thank you very much, John. I've just been told 10 minutes behind on the agenda, and we need to move on now. A lot of these are assurance. I mean, just on the quality committee report, there were a number of reports and appendices which are all there for us. But so if we can try and keep it to the allotted time, that'd be great. Anna, your last report on quality.
Thanks, Jess. I think we've got 6 reports, 5 for assurance, 1 to note. The IPC is there to note. The RES and the DES this month.
And that's the
the
workforce
race
equality.
equality and
And the disability.
EDI annual report, also due to be published on the 31st. And so obviously feedback on those would be particularly helpful. They have been through quality committee. I think I won't say any more about the BAF other than that I think the committee felt that we certainly needed to do some more work in order to get greater clarity for quality committee. On suicide reporting, I just wanted to note such an important area for us to welcome the progress we have made on integration of data and getting the right data. I think it's something that we're beginning to see come through the work. On infection prevention control, we have good levels of compliance. We still have concerns about our flu and COVID immunisation rates, but these are down nationally as well as locally, regionally. And finally, on the provider collaborative, the board to note that there are 18 beds closed across our footprint. No incidents, patient safety incidents that have met the threshold for PCI. And finally, short kill close admissions certainly does increase the risk of out of area placements. I'm sure you're all aware of that, but those are the things I want to know. I just wanted to say thanks to Rosie, because we had our meeting last week, an enormous amount to condense. You've got a slightly different format, as you see, you did a brilliant job in a very short space of time. So I felt that you needed to see the detail.
Yeah.
And obviously we're very happy to help.
Thank you very much. Well, over that to Rosie. Particularly, you're keen to get some feedback on the race equality framework and the disability equality.
We certainly felt that these were really good reports, really clear, showed us where progress had been made and where we still need to do work. But there was a clarity in there that was really commendable.
For me?
No,
you're
yeah,
good. Yeah, okay. Thank you very much. Thanks, Anna, very much indeed. To the medical revalidation and statement.
So this is the statement of compliance we have to approve annually. This has already been presented to people at Culture Subcommittee on the 22nd of September and the Quality Committee on the. So the request is to approve the report so that it can be signed off and submitted to NHS England in the next couple of weeks. In short, it sets out the activities in the revalidation team, and for instance, it describes how we have 221 doctors as we're the designated body for, 215 appraisals for those doctors. 67 of those doctors were due revalidation in the last year. We've made 56 positive recommendations out of those 67 and requested 11 deferrals, which I think you will also see in the paper the feedback about the quality of the experience of the appraisals and scoring extremely high. Team very highly valued by.
Good. Brilliant. Thank you very much. Dinesh.
Just a quick one. Do we have any honorary consultants?
Possibly through
the
through the university, but they would not be relevant for this report because we would not be their designated body for an honorary consultant.
But they would have to have academic and clinical appraisals, wouldn't they?
Yes, but so this report is focused on our duties as a designated body and who I am the responsible officer for.
So we blame you.
Actually, I'm blaming you or give you the location.
Thank you.
Okay. Well, ask Jackie to join us for the meeting. Good. Well, thank you very much for joining. Probably know everybody, don't you, Jackie?
Big meeting.
Yes, it is. Yes, it is. Over to you. Well, Jackie is our Freedom to Speak Up guardian, and yeah, we need to get an update. And thank you very much. Over to you.
Yeah, I'll just say a couple of things so we can have a discussion because there's a lot of material here. The first thing to say is the Freedom to Speak Up policy is a policy that we've had for quite some time. It is the nationally approved one that we adopted over 2 years ago. So the only thing we're changing about that is the last appendix about detriment. And I have been to the policy committee who've picked up 2 or 3 tiny changes that are more typo type level. So we will make those changes once you ratify. So just to let you know, there's a couple of tiny little tweaks that will be made after you ratify it today, if you do. And the second thing to say is just the context of the report. It's been a challenging year or so for Freedom to Speak Up because there's been a national review of patient safety, and that's included the National Guardian Office, which is now going to be abolished. And so we've had a sort of year or so of trying to plan within Sussex Partnership our function and to improve it, but not really knowing if it's going to stay or what it would look like. So I think we've had plans that we've had to shelve, and so some of our plans now are a little bit more of a holding plan. But of course, now we're starting to be clearer of where things are. So hopefully going forward, we can start to, expand again, really. So that's the context to the report. It's why it might seem a bit confusing to be pushing and pulling here and there. So that's all I'll say, because I think people can comment on the report, because there's quite a lot in there.
Thank you, Jackie.
That's okay. Any questions or comments?
And obviously regularly and I hear from you and it the way that this work has developed and more champions, more presence, and you getting around the trust. I just want to say thank you on behalf of all.
It's been lovely working with you, Anna. I'm sorry you'll be moving on, but it has been a real pleasure. So thank you for your support as well.
I went to one of the meetings with champions. Was a really motivated group of people. Which takes one of the questions before we go to Nabil. Just give us your reflections, Jackie, on the fact that there's it's a good policy. We have a good relationship with you. I see you going to be the executives and regular meetings with Jane, me, and Anna, which is good. And of course, the National Oversight Framework drew attention to the fact that our staff survey, there's some concerns around people being concerned about speaking up. What are your reflections on that? What more do we need to do to address that going forward?
It's the golden question, isn't it? I think going around to different sites, we have to be aware that it's really uneven. Some areas have a really good speaking up culture in their teams, and it's really clear that staff speak up, whether they fill in their survey or not, that there are good cultures. And I think in some areas then maybe there's not such good culture. So I think it's really important to see it as an uneven thing rather than a sort of one size fits all. I think there's more cultural work to do around speaking up feeling like a gift. So the National Guardian Office talk about speaking up from staff as being a gift to the service. Look, I'm telling you something you might not know, just so that you'll know. But I don't know if that's how it's always experienced. And so staff sometimes feel they are giving a gift. They don't always feel that. Sometimes they're really annoyed and they bloody want to tell you something, But a lot of the time they feel they are helpfully telling people things. And then those receiving that might experience it also complain to another unhappy staff member. It's another thing to do. And, how do I deal with this? And, so sometimes it's around sort of the culture of getting everybody on side to feel that this is designed to be helpful and having the confidence just to speak to our own staff who actually just want someone to call them up usually and so can we have a quick chat about this and try and resolve it? And we are getting more of that, I think, in that more people are responding to concerns than they're used to at different parts of the organisation. But I think there's ongoing cultural work. And I've been supporting the staff survey work recently because it isn't just about how people respond to Freedom to Speak Ups. It's also about getting more people using what we call business as usual speaking up. So the staff survey is a routine form of speaking up, and it's important people see it as that. And again, not just another thing on the list to do. So I've been helping with some of those road shows, and I've done supported videos and things like that. So I think there's something cultural, Sean. I don't know how we do that, because I think all our ducks are in a row. We've got the right policy. We've done all those kind of things. It's how do we shift the culture? And what else? Yeah, that's the. I don't have the answer for the cultural bit.
One of the things that will help us is we are, as we said a few times during this board meeting, we're investing and putting a lot of energy into our continuous quality improvement programme, which will get underway. But that could take a bit of time. But you know, we can identify the pockets where maybe there's cultural issues that we need, and that should come out in the early days of the quality improvement programme. But it's good to have your reflections on it. We've spoken a couple of times about the senior leadership team, about 50 of them, how important they are, and do you have access to join them? Is there any more we need to do to give you access and support those 50 really crucial leaders that we have in the organisation?
Yeah, I don't know if there is more work to be done, actually, because I don't know how many people reference them. When I go around, people talk a lot about the executive. I very rarely hear them talk about the senior leadership team. So I don't know how visible they are to staff in terms of what, because I imagine they're carrying most of the stuff day to day, aren't they? As senior leaders.
Yeah. Thank you. We'll continue with the show.
Thank you for your paper. I'm enjoying reading it. My view as a new led feels a little bit different to what I'm taught around the table at the moment. So forgive me, I'm just going to kind of share it how it is for a second. So when I look at Appendix 1, and I look at all of the scores of 4 and 5 across Appendix 1, it works out that over 90% of your scores are the highest scores that you want to have. Whereas a 3 is we're doing generally well, but we've still got work to do. And I think that Appendix 1 doesn't reflect your staff survey scores. I understand that freedom to speak up is one small part of concerns overall. I in my day job, I've done a couple of things on channels, but I just feel that this gives us a message. This appendix says nothing's seen here, doing really well. Our staff survey results, something else. So I don't know whether we need to be a bit more honest about where the work is to do, and maybe it's the point you make around actually, I don't know the answer about culture, but let's go back through this appendix and say to ourselves, actually, we're probably 1 and 3 here than we are 4. So that's just a thought from me as a new Ned coming in.
No, if you have any reflections, Jackie, it's fine. And Colin is, because you're...
Yeah, I mean, do you want me to go first or Colin?
You go first, then Colin.
Yeah, I mean, I think that's valid. So I think that's something for us to think about. I think it's worth just acknowledging the difference between the assurance tool and the questions that come up on the staff survey, because they're sort of about slightly different things. Obviously, they're related. So the assurance tool is about the FTSE functions. So it's about the Guardian and the NEDs and the executive leads and the training and the policy and all those kind of, things that you have to have in place as an organisation. And when there was a well-led review that published last year that was done independently, they did highlight as one of the sorts of highlights that the Guardian function, was highly regarded. People knew who the Guardian was. They knew how to speak up. So that's what that bit is. Although some of it talks about the organisation as a whole, it's about having all your sort of ducks in a row. The questions on the staff survey are much on asking about the Guardian or how do you speak up or do you know how to speak up, any of those things. It asks, do you feel secure to raise concerns about patient safety? And do you think anyone's going to do anything? So they're much more subjective and they're much broader around, you can kind of have everything in place. That doesn't mean people feel it's secure. What does that mean to them? Is it secure to speak to their manager? Is it that they can't speak to their supervisor? Is it they feel they have and it hasn't made any difference? Do they think the issues are so big that we all know what the issues are? What's the point of speaking up? We know we don't have enough resources in the NHS. That's the bit we don't know. So they're related documents, but they are a little bit different because one is strictly FTSE function and the other one is more staff survey and how staff feel. But you're right about the work that needs to be done because I think our results are not going in the right direction as a trust, and I can see why you're then wondering how does that add up? Yeah.
Well, Colin on this one.
was going to say, Ismail, do you want to come in and I'll close?
I was going to say, just for, I was the exec lead when we did this as opposed to Colin on this one. So I think it is, as Jackie said, because we talked about this quite a lot when we were filling it in. Actually, for me and I and Jackie, we had quite a, because initially when it came back, I also said, it's a lot of 4s and 5s. And I think it is to that point that the questions are quite specific of, do you have a policy? Do you have a training? Do I, as the exec SRO, have I been trained? On the questions that are more subjective, I think the majority of those, quite a lot of those questions have come out as a 3. Having said all of that, I think we absolutely should look at it. And I think we absolutely should say, be honest and say, I think for me what this is that this is about the FTSE function. But our staff survey says we have a wider problem. So it's beyond FTSE. What else is it that we need to do to make people feel like they can raise concerns, do it safely, and that it will be acted upon? Because I think what this highlights for me is beyond the FTSE function. I think as a function, we've got a full-time person, which many organisations don't. It reports into the board, which many organisations it wouldn't. That's all great, but our staff survey score says many of our staff don't feel confident raising concerns. And I think it is that nuanced difference about that much more, I guess, emotionally based, I don't feel, as opposed to there's a policy and there's a process. So I think we absolutely need to look at it all, and I think it will need to be part of the work we need to do in the round around what comes out of the staff survey.
Yeah, no, the other point I was just going to make was that we have National Freedom to Speak Up Week coming up, 2 weeks' time, I think it is. And there's a really kind of comprehensive kind of sort of engagement piece to fit in that, because I think one of the things that Jackie and I talked a lot about is that alignment between that broader cultural piece and then the specificity of the freedom to speak up. So there's a programme of work that ties Jackie in with the Divisional Directors of Nursing and Quality and actually going out and sort of showing that kind of collaborative piece, because we absolutely want to get the culture of speaking up throughout the organisation. And then also we have that very sort of specific kind of function as well. So I think looking at the FTSE function in the context of our response to sort of the staff survey and that alignment, I think is incredibly important here.
Jackie, thank you very much indeed.
Nice to see you.
Sorry, just very quickly, 2 quick points. I wasn't going to mention the first point I'm just about to make. I'll come to the second, which is a governance point. I think, like Cheryl, it's really interesting you come in and you don't see what others see. It's really interesting. And when I look at the well-led developmental review that was done and the work that David is currently doing right now is looking at the quality governance, it's really important to connect those dots together. And the feedback from well-led, you will recall, it really about that second line of defence, second line of assurances, second line of governance. And that's where I'm really focused on right now, is developing and giving this board a full oversight, the early indicators about where things are and how they're progressing. So more work to be done, that's what I'm saying. The point I wanted to make about the governance element is, thank you, Jackie, for saying that there's some tweaks to be made to the policy. Because of its importance, I think it'd be really great if we can recirculate it to the board. So just for minutes purposes, after the changes, we recirculate to the board so we have full visibility of the policy. Thank you.
Okay, so we'll approve the policy with those amendments changes that we discussed here. Thank you. Taking us on to the To Be a Good Partner Charity Committee report, Chair, and one of those really quite a privilege to chair the charity report. It tends to be good news. The committee's functioning well, our charity's functioning well, and the financial balance sheets are all very positive. Over £100,000 worth of grants secured of late over the last year. So strong financial management and alignment with the strategy. One of the things that we did feel that was a bit weak is aligning what the charity did to our objectives. It's got a lot stronger on that. And in fact, the last meeting we discussed the importance of aligning it with the research and development work that we do, Oliver, with our universities. And there are meetings underway where Rachel Duke, our director, is meeting up with the R&D department, which is just really quite important for us. But that's all I want to say. But I do want to finish on a positive sort of fun note, Colin, you'll have to tell us because I haven't looked at your WhatsApp yet, but there was an event over the last few days that the charities were involved in.
So the charity working with Natalie, who is an incredibly passionate OT, and I think we just absolutely have to shout out Natalie in the context. I've completely forgotten her surname, which is really unhelpful. Thank you. Have developed a piece of work with Fatboy Slim, where he sponsored some DJ workshops for people who have, sort of lived experience of really quite severe and acute mental illness. And last Wednesday evening, there was it's the first they've done it. They had no idea how it's going to go, but it was basically a kind of a gig, I guess, held on Brighton seafront in Rockwater, which gave each of the people who've been on the course the opportunity to take the stage and lead their sort of section, whether that's singing, rapping, mixing. It's probably the first time I felt like the dad in the room, but apparently my dancing was passable. But it was probably, and I'm saying this very, very genuine, it's probably one of the most humbling experiences I've had in my entire NHS career, was watching how our staff, people who were, people who were using our sort of services, families and carers, were just one united group, experiencing, some fantastic music. And actually, they were really talented. It wasn't even like we were having to, it wasn't like a school concert with violins playing. It was an absolutely incredible night. So my exec colleagues are bored about me hearing it. There is, and I know it's just gone out to charity committee, there was a really lovely write-up that Channel 4 have done. We can share it with the full board outside of here, with an interview with Norman Cook himself. And, the plan is absolutely to maintain that commitment, because I think it really demonstrates the power of non-traditional interventions to help improve health and well-being. So, awesome evening.
Can I just say that, for Colin, that the fact that he still calls his body movement dancing means he's definitely
Yeah. So a big thank you then to Natalie Rowlands. Again, I remember meeting her in Shepherd House when I first started, talking about the partnership with Norman Cook. I was thinking, where is it going to go? And it's just another example of good empowerment, really. She's got on with it. And that's it. To hear what you said is the most humbling experience you've had. It's quite strong. Yeah, that's really good.
And nothing against violence.
Very good. Yes. So, and moving on to reflection on sustainability, Finance and Investment Committee, and Neil can't be with us today. Viola.
Okay, thank you, everyone. So this report summarises what we discussed at the committee on the 26th of September. I'm obviously delivering the report on behalf of Anil, who cannot be here. There's no real issues to be escalated to the board, so this is just for assurance purposes. I'm pretty sure everyone's had time to, to go through the numbers. I'm not going to go through the numbers in a great deal of detail, because I actually think there's a lot more discussion to be had about some of the other issues, but very high level. We looked at the BAF, and as Nabil has already explained earlier, there's still some more work left to be done, and so we're going to see more about that later. In terms of month 5 performance, essentially we're on track, which is good. So nothing to worry about the way that the numbers, show. So we did have a deficit of £600,000, but that was where we expected to be. Pay spend was on budget for the month, but 1.5 million below plan on the year-to-date level. I will come on to why that isn't exactly the boon that we think that it might be. Looking at the year-to-date figures, we're in a good position as we're on plan with a deficit of 4.7 million. And we're on track with delivering our year-to-date financial recovery plan, which is at the moment 10.3 million has been delivered. But when we start looking underneath those numbers as to actually, what's happening, what we're seeing is provider collaborative, not an issue, that's breaking even. So it's all about what's going on with us, the trust by itself. SVFT alone, income went down, but then costs went down even more. So that's why we're getting the slightly above plan year-to-date figures. We've achieved savings in pay costs, but that's mainly been due to vacancies. So in a way, that's kind of temporary and not necessarily a good thing, because we need people in those roles to deliver the great care that that we need them, particularly in areas like CAMS. We all know about waiting lists and dementia services, small services. It should be noted though that agency spend has been declining, but I think we've talked about that in another board. All the hard work. Talking about cash, I'm moving quite quickly. So we're in quite a strong cash position with 86.2 million, but that does include some things that that we need to sort of take out because it's not really our money. So it's like provider collaborative balances, and then we've got the capital program. So we're already committed to spending some of that money. So when you take all of that out, the adjusted cash position is just about 26 million. Capital expenditure, we're underspending. We've underspent by quite a bit. So we're looking at 10.7 million is how much we've spent, and we expected to spend about 15.8 million. But that is mainly just because of lag in a project, which is what Usman spoke about, the Coombe Valley. So hopefully that's going to unwind at some point, or it might mean that we just won't be able to use the full funding. So while it does seem on the face of it that our numbers are in the right direction, right place of travel, when we actually start digging down, there are issues that we need to just be really wary of, and that's got to be what's happening with our capital expenditure is one, and what's happening with the workforce optimization scheme. There was a lot of non-recurrent savings that we're doing because we are doing well. The financial recovery plan, we are doing well according to that, but some of that is non-recurrent. So there was quite a lot of discussion in committee about, well, actually, this is great that we're seeing that, but we can't do that again next year and then the year after. So there has been a lot of work going into looking at that, but it is something that the executive committee are alive to. And they did talk about some of the different controls. So, while we're not fully, I don't want to say happy, but, we would like to be in a better place than we are, but we did get assurance that, that the team are doing what they can given where we are. So any questions?
Excellent, very comprehensive, Abiola. Thank you very much. We'll come to Nitinda. We've said it before, but our cash situation is sound, and the position in month 5 is good. And Usman should take credit, and your team, for helping us with that. But it is everybody's responsibility. And when we're looking at the national oversight framework that we need to improve on, finance will be weighted quite heavily on that. So our performance on finance will always be a big focus. So thank you for that. And finally, on the capital expenditure, yes, it's sometimes frustrating with the lag in time of the money. We wouldn't want to lose the money. What is a degree of flexibility where we can use it on estates, poor estates? Sometimes we go as non-executive directors can see that things need to be improved.
So specifically on the capital, the underspend is entirely driven by the Coombe Valley Hospital, and we will work with both Kia and with NHS England to ensure that we don't sort of detrimentally get impacted as a result of the delay that's happened, and that we don't lose that funding.
Thanks, Chair. Obviously, a lot of work is going on, and I used to be on the Finance and Investment Committee earlier, and I know there's a lot going on in the background. But just had a couple of questions because I'm not as close to it now. But one was, I know the year-to-date deficit is 4.7. That's in line with plan. But when I look at the target savings for the year, it says forecast delivery of 21.7 versus the target saving of 33.85. And I'm wondering whether our target, and maybe I'm just not remembering this, whether we were. Is our forecast delivery 12 million short of our target? Is that what I read over here for the year? That is one. And then the year-to-date savings, you talked about the 10.3 million supported by vacancy management, which is great. I'm guessing that is counted towards the recurrent savings. But then we also, how do you balance that with the fact that we do need more people? So yes, we are saving money for not having people. and we are reducing our impact for agency, but then we also need to get more people, because in some places, how's that recurrent? Because ultimately, are we eliminating those positions completely?
And I think it's a really good question. I think it's at the heart of many of the comments that have been raised. So in terms of the vacancy control, which is a significant driver, covering off, I think it's fair to say, the current gap in the workforce optimization program. It is non-recurrent because those posts are, in effect, not being deleted. We're just saying at the moment we are not recruiting to them. The work that is currently happening at the moment is, in effect, a very detailed review of those posts to understand how many of those will possibly become recurrent or could become recurrent. But that is a set of choices that would need to be made. And that's why we haven't brought it here in detail today, because actually there's quite a lot of work that needs to be done. The teams who are meeting today, so the Financial Recovery Oversight Group met this morning and was talking through the details of that. We'll have additional sessions with senior leadership teams. It will also come through the SIG committee to understand, of the non-recurrent actions that we currently have badged, how many of those could potentially be shifted to becoming recurrent. And we'll, as John said, we've gone through a really, I think, detailed process of being clear around what is a restricted post, i.e. we're not touching those posts. These are clinical posts, inpatient services, urgent care, crisis. There are no controls on those. I just want to be really clear about those. If people need, if teams require people in those services, they recruit them. In fact, I think we've actually freed up some of the controls around those teams. It does highlight, though, that there is a significant number of roles we hold within the organisation, many of which have been vacant for a significant period of time, and that we continually, in effect, budget them back again, only for them to remain vacant. So that's where I'm saying it's not quite as simple as saying, because it's a vacancy control and it currently shows as a saving, therefore it can't, there is a process we need to work through that says there are a significant number of posts within our organisation that have been vacant for some time. We have not recruited to them. We are not aware that that has generated an adverse outcome. And therefore, as we move into the 26-27 planning round and working through what happens at the end of this year, what we will be trying to address is how much of that, what is currently labelled non-recurrent saving, could potentially become recurrent. Hopefully that answers
that definitely answers the question. Just one question, which was, is the target, are we saying we're going to be 12 million short of the target setting till 3.85 and forecast?
Yeah, that section, I think we just, I'm sorry, I wasn't around, so I haven't sort of seen that. We are forecasting full delivery of our savings programme. What we're not yet certain about is what the exact number of that will be non-recurrent or not. Okay. So we will deliver, I'm confident that we will deliver £33.85 million in savings. We will deliver our year-end position. I think the question for us at the moment is what's the balance of recurrent versus non-recurrent in that. The Finance and Investment Committee had an initial conversation about that on Friday. We will have further discussion, including with the board, over the next sort of 6 weeks, I guess, before we come to finalising what our positions will look like as we move into next year.
How do we understand the join up between service transformation and our CQI programme and the money? How do we know how having neighbourhood mental health teams and redesigned campus service, so on and so forth, and that left shift is going to impact on our requirement for more costly bedded services? And, you know, are we moving to a non-bedded rehab model, for instance? So how do we join up the sort of service transformation and the finance conversations to get that more strategic shift so that we're improving quality and patient outcome while saving money and while doing more services? How do we do that triangle? That I think is really important.
Very, very fair point. I know from a national perspective, a lot of the intervention sort of studies and health economic studies on interventions that are more modern and more effective in psychiatry do have a good business case for television. So we will use that and better quality services. Let's get John and Colin. We'll give you a little bit of a rest, unless you want to come in, but John and Colin on that.
Thanks. So just to come back on your question, Kathy, I think so the approach that we would take is this is not just Usman's domain, so hence wanting to sort of come in and speak. So, but I think you make a really sound point. So if I think around the cases for change that we did last year, so we did dementia, we did rehab, we did community. They were specifically part of our transformation program. They were always part of our transformation schemes, and we look to accelerate them as part of our financial recovery. So, and I don't see those two as mutually exclusive. It was about the right services for the right people to meet the right population need. And the fact that they delivered a financial saving was advantageous and part of our program. And we would seek to apply the same methodology. So if I can think this year of some of the changes that we're looking to make to our inpatient state around forensic services. So a bed reconfiguration to mean that we're offering a greater number of MSU beds rather than LSU. So directly related to our population. I think you asked a question earlier around where is the under delivery in our workforce optimization scheme. So it's not around vacancies, it's not around agency spend. It's around the temporary staffing that we use to manage the clinical and therapeutic observations on our inpatient wards drives a significant use of temporary staffing, which brings me back to our CQI approach. So that's been a long-standing challenge for the Trust, and we need to resolve it. And if we do resolve it, it will be impactful on our spend. But the spend is not the driver. Actually, it's about the quality of care and getting it right for patients on our inpatient ward. What methodology do we want to use that? We want to use the continuous quality improvement methodology, because so far taking a more managerial financial approach hasn't worked. This is clinical behaviours. This is clinical risk. We need to apply a clinical methodology to it. So that's how I see the triangulation. Of course, there's process issues. Of course, there's operational management. Of course, there's scrutiny of it. But actually, to get to the heart of the matter, it is around a CQI approach.
I completely agree, and I think that probably as a board, we never saw those business cases as a board, so we didn't really have the visibility of it to understand how that clinical transformation was driving improved outcomes and financial sustainability.
Because I thought we'd seen some of the organs.
But whenever we were at Buxton Park, I was saying I didn't think I had seen it, but maybe I missed them. Sorry.
I mean, and these sort of things should come to the board.
Sorry if that's my bad, but I don't remember. But to have seen them more explicitly in the board reports would be helpful.
Finally, Colin.
Yeah, I guess just 2 points. So one of which to giving the assurance about the connectivity. So we have a strategic sustainability and improvement group, which is a exec-led group of which all of the execs other than Jane attend, along with all of the clinical leads, divisional leads, etc., etc. So we don't have a separate sort of subgroup, if you like, that just does the finance piece. Finance is one agenda item, because I understand why I keep banging on about the fact that finance is one of our strategic objectives for this year. It is not the only strategic objective for this year. So I guess there is a group in which oversees all of the main kind of sort of transformation programs within the organisation, as well as looking at the kind of financial piece and where are there transformation programs that have a financial delivery element to them, and where are the transformation programs that don't have a financial saving associated with them, because we're trying to invest, grow in areas of sort of deficit. So I guess there's an assurance, if you like, that there is a group that looks at the totality within that kind of operational part. I wonder as well whether there's just something about so on the later on, one of the things that we're going to talk about is our planning approach in a bit later on this afternoon. And I wonder whether we come back to that question at this point as well, because there's something about being really clear about we're going to need as a board to just think about how we do the rhythm, given that we've got medium-term financial plans and various other things kind of sort of to do between. So I just wonder whether that question would be really helpful to maybe pick up as we stress test that item, if that's okay as well.
Thank you, Chair. After that very helpful and useful discussion, slightly boring but important governance task, appreciate the honour. The committee also approved the standard reference following the committee governance review, just for the board to note. And I should have said the same to the quality, given that I did not point it out. Can you note that the quality committee as well, please? It's an important feature because our teachers are really
Thank you. Thank you. And finally, our audit committee report.
Thanks, Chair. No issues to be escalated to the board of director. To the board, I am just going to run through very quickly. We had a regular count of fraud and internal audit reports. For count of fraud, we had 4 new referrals. Like the freedom to speak up, we want new referrals. That's a good thing. We want more and more referrals, as many as possible. Which is good for us. The board assurance framework, we talked earlier about the fact that we discussed it at the audit committee, focused on governance, but also looked at all angles of it, which is a good led to some good discussion. Talked about workforce controls and risk, especially compliance monitoring. We had Usman talk about the NOF results, and we spent a bit of time on that, what that means, and why we had the rating we did, and what the financial part of that is, and what the engagement part of that is, just to understand that a bit more clearly. And finally, we had the information governance and security policies for ratification. Nothing major to report on, pretty standard.
No, thank you very much indeed. That concludes the business. Are there any other items of business? Got anything?